Great. We are back after a very short break. I apologize, everyone. So our next segment of the suicide prevention testimony, we're going to hear directly from our provider community. So we have Thomas Delaney and Becca Bell with us. I'm going to let you both introduce yourselves. I'm not going to do introductions of us since we're already behind. We're going to get right into it. So I don't know who's going to start.
I'll start.
Great.
I'll start, and hopefully you can hear me okay.
Yes.
Thank you so much for having us back. Both Tom and I were here speaking to your committee last year, talking about suicide prevention efforts within the medical community. And we actually have a bunch of updates on how things are going and some of the efforts we talked about last year. I also know there's a bunch of new faces on the committee this year. So we're going to review some of our work and some of the work of our colleagues, and then we have some asks for you all at the end. So I'm going to start by sharing my screen, and
I just want to confirm, Becca, we don't have these this presentation yet, right?
Right, you don't. Yep, I'll send it along. Yep.
Okay, great. So just so everyone knows, we're going to follow what's on the screen.
So I'm going to introduce myself, and then I'm going to hand it over to Dr. Delaney for him to introduce himself and get started on our presentation. So I'm a pediatric intensivist at UVM Children's Hospital, which means I care for infants, children, and adolescents who need to be in the intensive care unit due to either critical injury or critical illness. And that includes young people who have attempted or died by suicide. I'm an associate professor of pediatrics at the College of Medicine, and I have some leadership roles in Vermont medical organizations like the Vermont chapter of the American Academy of Pediatrics. I'm president-elect of Vermont Medical Society. And then the work that I do outside of my clinical work is really around injury prevention with the Vermont Child Health Improvement Program. And I just have a smaller list of groups that I am active in that is relevant to this discussion we're going to be having today. So probably most relevant, I sit on the Vermont Child Fatality Review Team. So this is a group that reviews all of the unexpected child deaths, including all the pediatric suicide deaths in Vermont. And then I'm gonna hand things over to my colleague, Dr. Delaney, to introduce himself.
Hi, thanks for the opportunity to talk with you all today. I'll just make the clarification. I'm not actually a provider. My research and educational activities are very involved with provider, and I did spend many years getting my psychology degree, but I don't actually practice.
Great, thank you, Tom, for that clarification.
Yeah, I wanted to, I'll do the similar brief intro to Dr. Bell. I'm an associate professor of pediatrics at the UVM Larner College of Medicine. The views I'm sharing are my own, and they don't reflect either UVM or any of the other organizations I work with. I do a lot of teaching. I teach in the first year medical curriculum. I teach 4 different classes in the Master's in Public Health program. And the other hat I wear at UVM is actually evaluating a bunch of different initiatives in the state. So the Zero Suicide Initiative that was mentioned in the earlier testimony. And I'm also an evaluator for both of the current grants that Nick Nichols talked about. So the Comprehensive Suicide Prevention Grant from CDC and the new SAMHSA Youth Suicide Prevention Grant. So a lot of what I'll be talking about is related to those. We also have to acknowledge that a lot of the work that we're sharing with you is it's not just Dr. Bell and I doing it. There's a lot of other people involved. So I want to acknowledge the educational technology team at University of Vermont Larner College of Medicine, especially Raj Chawla, Bruce Kimball, Lori Gallus, Rose Martin, MD, who was a student who graduated, and especially Abby Bierman and Gail Finkelstein, who are at the UVM College of Medicine. And also Dr. Bell and I were supported by a grant from the Farmer Foundation for some of this work. So next slide. Yeah, I don't think we really need to do the overview in detail. We're going to talk very briefly about some national trends that are related to lethal means safety and suicide. I'll talk very briefly about intentional self-poisoning, and then we'll transition to firearms, and Dr. Bell will talk a lot about some of the projects that she's involved with, and then we'll have some take-home points at the end.
Great.
So I know this morning you got a lot of data about trends in Vermont specific suicide deaths. I just wanted to point out that the national trends are also scary, very scary. So in 2021, which is the last year that I'm aware of, we have complete data for nationally, there were almost 48,000 suicide deaths. That's a 4% overall increase from 2020. And it's in terms of rates per hundreds of thousands of people, it's actually very close to the 2018 peak rate that was tracked nationally or identified nationally. And we know actually from Caitlin Quinn's presentation this morning that Vermont's actually had a record-breaking rate and record-breaking count of suicide deaths in 2021. The changes that we're seeing nationally were that males had a substantial 8% increase in suicide deaths. And specifically, sorry, that was 18 to 14, 18, it's probably 24-year-olds.
Thank you.
Then, sorry about that. That would be weird. And then there was a 3% increase in males overall, a 2% increase seen in females, and there were no decreases seen in any age group. So nobody was actually getting better at the population level in terms of suicide deaths. We can go to the next slide. This is data that I think you probably also got a preview of in the morning. It shows on the left ED visit rates. So these are visits per 10,000 ED visits. And it shows them for suicidal ideation and self-directed violence. And you can see that for the youngest age range on the left, it's about 3 to 1 females to males. So we see a big gender disparity there. There's still a gender disparity for ages 15 to 24. It flips for ages 25 to 44, where males are then becoming more likely to visit the ED for suicide and self-harm, suicidal ideation. And then it goes a little more female in the older age ranges. Earlier, there was a question about BIPOC risk factors for BIPOC Vermonters. On the right, you can see that looking at these emergency department visit rates, we have a substantially higher rate, and this is from 2022, first half of 2022, among BIPOC Vermonters. That's somewhere in the neighborhood of a 35% relative greater number. And then if you look at the far right, you can see that most of the overall visits that we're seeing at the ED are for suicidal ideation. So people are getting referred, either bringing themselves to being referred directly to the ED because they are expressing the desire to end their lives or the capacity to end their life. And then a lot of the ED visits were also specifically for poisoning that was coded as having suicidal intent and other self-harming behaviors. So we're actually going to transition and talk a little bit about some of that poisoning. So intentional self-poisoning is defined as the ingestion or inhalation of a specified amount of substance associated with significant risk of self-harm. One interesting thing about the lifespan perspective on this is that it's usually not fatal in younger people. Younger people are incredibly resilient physiologically. However, as age increases, you do see a much higher mortality in older ages. We're also not talking about people whose intent was determined to be intoxication. So they're fully out of this, analysis. Although certainly there's some overlap with opiate use, unintentional overdose, and suicidality. There's some bit of a fuzzy boundary there that's not for discussion this morning, I think. And then we also want to acknowledge that intentional self-poisoning is almost certainly an undercounted phenomenon. Many people who engage in this behavior are going to spontaneously recover, and they're not going to wind up getting medical help. No one may ever know that they had an episode like this. And if they're not being identified by, say, friends or family members or a medical facility, they're just not in our statistics. And we believe that there's a good number of those individuals. One of the things that we focus on, particularly with younger people, is the idea that we need to do a better job with them. And we know that intentional self-poisoning behaviors, as well as intentional self-harming more broadly, are upstream set of behaviors for future suicide attempts and deaths. And that's not for every young person who engages in these behaviors, but it's much more frequent for self-harming young people. And we know from different studies, most recently Keith Houghton, I think, individuals of any age who engage in intentional self-harm have a 1.5 times greater likelihood of dying by suicide during their lives. So it is a marker, a risk factor. And then we also know, specific to younger people, that 80% of young people who died by suicide had engaged in self-harming behaviors in the year prior to death. So this really suggests that there's an opportunity maybe to identify people. That if we can identify people more effectively, we might be able to intervene and prevent some of those downstream deaths. You can go ahead. I'm not going to give you too many charts on this, but this is a pretty important one. So these data are counts of calls to the Northern New England Poison Center, and they show trends pooled across Vermont, New Hampshire, and Maine. And these are specifically self-poisoning ingestions, and specifically the ingestions that had life-threatening effects and deaths. So poison center calls come from a variety of places and people, but they're often from healthcare settings like emergency departments. So the total number of these intentional self-poisoning life-threatening events in 2021, so all the way at the right, if you sum across those 4 lines, we have 262 events. About 80 of those were in Vermont. So 80 people is our best estimate for the number of Vermonters in 2021 who had a life-threatening or death induced by intentional self-poisoning. Something else we know from the data that isn't on this graph is that episodes are becoming more medically serious and lethal over time. So we know that across all age groups, the trend is towards more lethal intentional self-poisoning. And if you pull out just one age group, which is age 40 to 59, self-poisonings were 5 times more likely to result in major injury or death in 2021 than they were in 2012. And this strongly suggests that people are using different substances, or there's some kind of increased vulnerability among people. But it's a very disturbing aspect of this, these overall trends. Another thing I really want to point out, I had a graph on this, but we pulled it for time. The only group where things got worse in 2020 and 2021 is people under the age of 20. And this is incredibly important for us to acknowledge because I think it was mentioned earlier that, I think Chris probably mentioned this, that younger people were disproportionately affected by COVID-19. Their social lives and educational experiences were incredibly impacted in negative ways. And many of them are resilient, but there's still a lot of negative impacts of that. And we think that's probably reflected in the increased calls to the poison center, including for these medically serious and even lethal instances of self-poisoning. And this really suggests, especially in combination with the previous slide, what we know about getting upstream, this is only going to get worse. We really need to focus on how to intervene, how to better identify, earlier identify, then provide evidence-based treatments, and then do appropriate follow-up, especially for younger people when they're at the start, for many of them, of this sort of negative trajectory. We can go to the next slide. So we do think that there's some opportunities to make a big dent in terms of intentional self-poisoning. And in particular, we think that supporting professionals, especially healthcare providers, but also community-based mental health providers and others, to do more in terms of actually screening for and identifying self-harming behaviors, including self-poisoning. And we know that it's a major concern of providers. And we know that the vast majority of primary care providers have had patients who engage in self-harming behaviors, including suicide attempts. And certainly if you talk to primary care providers in Vermont, it's extremely common that they've had patients die by suicide as well. We also know, specific to adolescents, that 80% visited a healthcare provider within a year prior to death by suicide. So again, there's the opportunity. There's really only 2 places where most adolescents are showing up. It's school and primary care offices. Most adolescents in Vermont are getting visits according to the right features and periodicity schedule. So we feel like it's a crucial opportunity for that sort of early identification, early intervention, and then appropriate follow-up. The drawback of focusing on primary care is that many healthcare providers were not specifically trained on identifying and treating self-harming behaviors. So they may lack the tools that are needed. We can go to the next slide. I mentioned Gail Finkelstein and Abby Biernan earlier. They are the authors of the Vermont Youth Self-Poisoning and Medication Safety Toolkit. This came out early in 2022. It reflects a lot of work by them and their colleagues at UVM Medical Center and at the Northern New England Poison Center. Excuse me. The toolkit is completely free and even includes free continuing educational units for several different professions, including medicine, nursing, and clinical social work. It was developed and reviewed by Vermont-based content experts, so it is tailored to a fair amount of our local sort of landscape. And it is aimed at healthcare providers, but we also feel like a lot of the contents are applicable to other professions. So this might be a useful tool, for example, for community-based mental health providers. So the toolkit is important. We think there's also strategies that have been explored a little bit, but need to be taken to a much higher level. And one of those that I've been involved with is distributing free medication lockboxes from primary care offices. I worked with a doctor of nursing practice student in the past year named Natalie Ray from UVM, and she did a really fantastic pilot project, and we were able to support 2 primary care practices in distributing lockboxes when they were identifying risk. And it wasn't just lockboxes, it was actually there was a form that collected a little bit of data and also had counseling prompts and care recommendations, all based on the toolkit that's on this slide. We also think there's a great opportunity to do some targeted education for parents and caregivers on medication hazards. So just as one example, not buying the 300 count Tylenol bottle from Costco, but maybe buying medications in smaller units is just sort of a universal prevention strategy that seems wise. So let's transition to talking a little bit about other means used for suicide and self-harm. This graph is from Caitlin at Vermont Department of Health, Caitlin Quinn, and the pie chart on the left shows that poisoning and cutting are the most commonly used self-harm methods. And we know from Caitlin's presentation earlier that these are not usually fatal. However, for actual suicide deaths, which are shown on the right, firearms are used in about 60% of cases in Vermont, and Vermont's a little higher than nationally for firearm suicide deaths. And this really gets at the issue of different levels of lethality that are associated with the different means that people use to take their lives. Go to the next slide. So lethality is the idea that, well, lethality is really the strongest predictor of actually dying given a suicide method that's used. And it's actually a stronger predictor than a history of depression or history of other mental illness. And when we're talking about lethality, we're really thinking about its inherent deadliness. Firearms are inherently more deadly than cutting, for example, or piercing injuries. Firearms are accessible, which is a really important factor for lethal means safety, ease of use, and then ability to abort mid-attempt. You basically can't abort the firearm discharging after the trigger has been pulled. Other attempts, like with medication or even to some extent suffocation, there is an opportunity to change the outcome.
I'm sorry, can I interrupt real quick? Can you just, is there any more context you can provide on your very first sentence there? Because we were talking earlier about, you know, someone having a mental health diagnosis versus not. So is there any background here you can provide?
Yeah, so I think it's upwards of 60% of people who died by suicide in Vermont have some history of a known mental illness. So it's definitely a risk factor. But if you think about how different factors contribute to the likelihood of someone dying, actually the choice of means is a stronger predictive factor than is a history of depression, for example, or current mental illness. So somebody is so much more likely to die if they use a firearm, or if they use a very non-lethal approach as well. That winds up being a bigger predictor.
I think that's helpful. And we have one other question and then we'll move on. Daisy?
Just to clarify, so when you say that the means is more of a predictor than the fact that someone at some point in their life has had a mental illness, are you talking about, can you distinguish between a mental health challenge and a mental illness, or is there any distinction there?
Great. That'd be a good like graduate school question. So I think mental illness is something that comes from the DSM-5, and it's a formal process to diagnose a mental illness. And I think that when I think about challenges, they might be more transient and they might be not officially recognized. They might be more temporary emotional states and not things that we would typically consider like, a diagnostic code. And it's actually a great question in the context of suicide and firearm deaths, because we're going to get into the issue of impulsivity. So younger people who die by suicide using firearms, they're a lot less likely to actually have a known history of mental illness, but they're more likely to have had an impulsive episode, maybe in reaction to some setback or romantic setback, school achievement, all sorts of different things that you wouldn't necessarily point to and say that's a mental illness, but it still set that person up for a situation in which they're making, dangerous decisions.
But if they meet, and the clinicians at the table might help me get clarity on this, if they meet a diagnostic as in the DSM-5, then they at least have symptoms for 6 months or more, persistent symptoms. And it could be a mental illness such as like anxiety or depression that, at least 3 people in this room experience. It's not necessarily something as severe as bipolar or schizophrenia. I just want to make sure that everybody understands it's not something, it's not necessarily a severe or persistent mental illness. It's often something as common as depression or anxiety. Those 68%.
Good point. You there, Tom? We can't hear you all of a sudden.
Your volume went away.
No.
Might be the microphone. His microphone is.
His headset. Oh, now you're on mute.
Is it us? No.
It's very faint.
Very faint.
Can you do it without your headset?
The wire maybe could be loose.
Yeah, that's almost what it sounds like.
Hearing it all now?
Still too faint.
Now speaking to that mic.
How about now?
That's better. Thank you.
It's probably a little bit tinny. I apologize.
That's okay.
My laptop's probably like 5 years old.
No worries.
If we can go ahead to the next slide. So this is just one piece of evidence that we have around the impulsivity. And we've already started talking about this, but we know that for many people who go on to die by suicide, you can actually study people who've made a medically serious suicide attempt who survived the attempt, and then you can sort of debrief and ask them about the circumstances that led up to the attempt. And this is an example of one study where they actually found that for a pretty substantial portion of the people who survived the attempt, there was less than 5 minutes between when they made the decision and they actually did the action that tried to take their life. And then there's also evidence that these more impulsive short-term attempts tend to be more violent. So that would be consistent with using a firearm or jumping from a height. And also they're less likely to be depressed, which is kind of like what we are just talking about. So they're less likely to have a longer term or persistent mental illness, and it's more likely to be seen as like a transient set of life events, maybe, or some maladaptive kind of reactions to life situations.
We have one question. Go ahead, Art.
When you say impulsive attempts more likely to be violent, what do you exactly mean by that? I mean, is a death by gunfire, by a gunshot, is that violent? Is that what you mean, or?
Yeah, it is definitely a more violent way, and it's just much more likely to actually result in a death than, say, a self-poisoning episode or even an attempt at self-suffocation.
But you don't mean the person is violent like to other people?
No.
All right, okay, all right.
Sorry.
All right, yeah.
Okay, I think we can go to
Good.
this slide. This is just a slide that puts the Vermont firearm suicide fatalities in the national context. So the darker the color of the state is, the higher the rate of specifically firearm suicide deaths. And you can see Vermont sort of sticks out a bit there in the Northeast. And we actually look more like the upper Midwest and some of the Western states in that we do have a lot higher proportion of firearm suicide than many of our neighbors, although New Hampshire and Maine also have really high rates of firearm ownership. But this is over a 10-year period. We actually, we're in the second highest group nationally for firearm suicide fatalities. And then we go ahead to the next slide. This is drilling down specifically on youth firearm fatalities. So you get really similar picture. Maine also looks really bad, but when we're specifically thinking about people under the age of 20 who died by suicide, or this is actually 18 and under, who died by suicide using a firearm, we're looking a lot more like the Western US states. And that probably has a lot to do with just accessibility of firearms, and there's more firearms in Vermont homes. And so young people who, again, might be more impulsive, thinking about their suicide risk, it may be easier in a very sad sense for them to actually gain access to taking their lives, just based on the greater prevalence of firearms. And we can go to the next slide. We definitely don't need to go into detail in this slide, but the powerful aspect of this, the main message of this one to me, is that firearms do play a particularly strong role in suicide death rates. And you see that even when you look across states. So this table compares suicide deaths in high gun ownership versus lower gun ownership states. And what it shows is that low gun ownership states have substantially lower suicide rates across all means. So not just lower firearm suicide rates. And this seems to be likely to, seems to be due to people just having more access to guns in the high gun ownership states. If you thought that people would take their lives no matter what, even if they didn't have access to the guns, you'd say, well, low gun ownership states should still have really high suicide rates. Their suicide rates should look like high gun states, but that's not actually the case. So there seems to be something, and it's correlation. It's definitely, we're not in the realm of causation here, but there seems to be a correlation where greater prevalence of firearms in your community are associated with higher overall suicide death rates. And that has to
hold on. All right. We're gonna go with Topper and then Alyssa.
I just have a quick question. How do you know high gun state or low gun state?
Right. So these are really survey data. So we don't have really great data recently nationally. And this study is actually old. It's from 2000. The data is from 2000 to 2002. And, you know, there was a long time where in the federal government, they weren't collecting firearm ownership data. And so it was sort of patchwork. But this would be from surveys of people in the community.
I'll just say that there, you can see, I don't know if you can read the bottom, but it does say the states that are included. So they took the states with the highest gun ownership and sort of added them together to make the same population as those with the lowest. Vermont is not included in here, but would have been one of the next states in the high gun ownership state. So you can see the states are listed below.
I just wanted to sort of sum up, because this can be confusing. What you're basically saying is that the suicide rate non-firearm.
So wait, I'm sorry, hold on, sorry. Tom, can you put us, thank you. Yeah.
Sorry.
Go ahead, Alyssa.
So you're basically saying that the non-firearm suicide rate is equivalent, but what makes these states high suicide rates total is their high gun ownership.
Yeah, so you just summarized that more clearly than I did. Thank you. There's like an additive effect of having a lot of firearms in your state that makes your overall suicide rate much worse than it would be if there were no firearms.
So Tom, please continue, but when you aren't talking, if you could go on mute, because there is background. Seems like when you talk, it's fine, but when you don't talk, so that's helpful. Thank you.
Yeah.
Great, all right, I think we can move forward.
So this is, we don't need to go into super detail about this one, but it's a really nice model from Professor Matt Miller and Kathy Barber and the group at Harvard that works on lethal means safety. And it just shows the progression between focusing on means restriction, which is, they use restriction, I use safety. I think that restriction is not the best language for this. But when you look on the left, the idea is that you're focusing on highly lethal means that people could use and making them safer in a lot of different ways. So then to move a little to the right, that goes into substitution. So if you can't get the firearm, what can you get to? And actually, very often people have a preferred method of suicide. And so if they can't get to their preferred method, they're actually not going to wind up making an attempt and therefore be less likely to die. So another strategy is to delay. And this really ties in with firearm safe storage. This is where there's sort of overlap between firearm suicide and sort of general concerns around firearm safe storage, because by definition, safe storage requires more time, more steps to actually get the weapon to the point where you could actually use it to take your life. And we know based on impulsivity that the more delays there are introduced, the more likely you are to make it through that sort of crisis period and then wind up not making the attempt. So that's really important. So the idea is that we're reducing the overall number of attempts, and that would actually lead to lower suicide death rates. That's the sort of logic behind this. We can go to the next slide. So reducing firearm suicides really involves a broad array of public health strategies. And we know that we have to be very data informed. We have to rely on the research literature that's out there. We know that we have to involve the firearm owning communities, and Vermont has a history of doing that, for example, in the Gun Shop Project. We know that we have to focus on prevention and getting upstream, and I would argue in particular for the younger people who are showing risk factors or not having risk factors detected. We know that policy changes can have an impact, and Dr. Bell might talk a little bit about those. And then we also know that access to lethal means is really important. So strategies like delay, distract, dissuade are effective in reducing suicide deaths. And we also know that safe storage, specifically for firearms, is effective. And there's research showing that for every step that's added to safe storage, there's a reduction in firearm suicide deaths. So even just doing one thing like having a trigger lock makes, at the population level, it makes people less likely to die by suicide death, by firearm. So this is actually the study I was just talking about. So the four methods that are shown to be effective, and they add on to each other, so they're additive, are storing the gun locked, storing the gun unloaded, having the ammunition locked, and keeping the ammunition in a separate location. So that's sort of like the gold standard that we'd like to see firearms owners using, and that we know based on research is actually associated with fewer people dying by firearm suicide. Go to the next slide. So we're down to our last two slides before we transition to Dr. Bell. This is, again, data from Caitlin Quinn at Vermont Department of Health. And this slide just shows the sort of prevalence, self-reported rates of firearms in the home based on the 2018 and the 2020 behavioral risk factor surveillance survey. So the dark green counties have the highest rates, so they're significantly higher compared to the state mean. And then Chittenden County in light green is significantly lower. But you can see that there are counties in their state that have considerably higher rates. And then the bars on the left are actually breaking out different populations. And when there's an asterisk next to the population, it means there's a difference. So we know that veterans are more likely to have firearms in the home, males are. The age starting around 25 and higher are more likely to have firearms, although it's not statistically significant. People who don't have a college degree or don't have some college are more likely to have firearms. People who are married and people who don't have children in the home. We can go to the next slide. And then this is data from 2018 and 2020 breathists as well. And what this shows is safe storage practice among those households that have firearms in the household. So these were additional questions after the question about, do you have guns in the home? And what we know from the breathists is that only half of Vermont households with firearms store them both locked and unloaded. And remember, those are two of the really key components of safe storage are locked and unloaded. So we have half of the households reporting that they do engage in the safer storage practices, and half that didn't say they were using these two methods. And then we also know that safe storage is practiced less commonly in specific groups. And when you look at the bars on the left, those groups are veterans, are less likely to store firearms locked and unloaded. Males, 45 to 64-year-olds, and then households where there's no children present. So there's little pieces of good news on this slide, right? So households with children are more likely to have their guns locked and unloaded, but we still think there's probably a lot of improvement that can be made for these subgroups. And with that, we can transition to Dr.
So actually, Tom, if you can just wait a minute, if you can go on mute for a second, I think there's going to be a couple questions. So Leslie, do you still want to go back and ask a question? Are you good? Daisy, I think you are good. Alyssa?
Just really quickly on this one last slide, do we have a sense using this data? Do we know how many children in the state of Vermont are living in a household with a unlocked or a loaded, unlocked firearm?
I don't think, based on the 2020 preface, that we can say that exactly. But if you extrapolate from the preface responses, we think it's around 13,000 households have what we would call a non-optimally stored firearm.
Okay.
So I personally have not seen the numbers that break that out in terms of children, but we are talking around 13,000 households.
Great. Thank you. We can transition to Becca.
All right, so I'm going to review a little bit about what Tom had talked about too, and put that into some of my clinical experience. So across all methods used, 90% of people who survive a near lethal suicide attempt do not go on to later die by suicide. And I think this is really important when we think about suicide prevention, because again, there's this myth out there that if someone attempts suicide and they survive, that they're just going to go on and try again, or if they don't have the method, if they don't have a firearm available, they're just going to find another way. That's always a phrase that we hear, they'll just find another way. And that's actually not what we find. It's not been my experience, and it's not been the experience of these long-term studies where they follow people decades out and find these are people who have made serious enough suicide attempts that they've needed medical care, and 90% of those folks go on to not die by suicide. So keeping people safe during these attempts and either delaying the attempt so they don't make the attempt at all, or making the attempt less lethal, is something that's absolutely worth doing and what we're really focused on. When we think specifically about those who attempt suicide with firearms, when we compare those folks to folks who use other methods, and Tom had talked about this and mentioned this study earlier, they almost always die. The fatality rate is very high. They're more likely to have made the attempt impulsively than someone who uses another method. So people who use firearms to attempt suicide are less likely to have made a suicide attempt in the past compared to those who use other methods. They're less likely, as you've heard, to have a history of depression. And so thinking about this particular group of those who die by firearm suicide, it's very hard to identify them, right? They're less likely to have had contact with the mental health system. They're less likely to have made prior suicide attempts. They're more likely to do it impulsively without a lot of warning signs. And then they're gonna die. And so thinking about how we really can't identify who these folks are, but what we can do is just universally make sure people are safe to protect them firearm suicide. So this is really leading us in the medical community to say we really need to what we call universally screen people for access to firearms. So not just waiting for that young person to come into the office and say, I've been thinking about suicide. That may be too late. We really need to be universally talking about this and thinking about firearm safe storage in the home and other things that we can do to keep people safe. I take care of young people who end up in our intensive care unit after a serious suicide attempt. And I can tell you that, and then I review all the cases of those who die. And especially among young people, these attempts often happen. And I can't underscore how impulsive these cases can be. They can be shockingly impulsive, especially among young people. And so when I talk to people who survived a suicide attempt in my ICU after they're better, they are there because they're very seriously ill and they're at risk of dying. And when I talk to them afterwards, once they're better, they'll say, they'll talk about their future plans. You know, I'm picking up my college courses for the fall. They have a plan for a trip over the summer. And when I talk more about what happened and what led to the attempt. It's really, they really oftentimes don't articulate wanting to die. It's not that they say, I don't want to be alive anymore, I want to be dead. They say, I was in so much pain. I was feeling so much pain and I really wanted the pain to go away. And that's why I did this. And so understanding that context when somebody is feeling that pain, what they do in that moment matters a lot. And we can't protect all young people or people in our lives from experiencing pain or experiencing a crisis like a breakup with a relationship or a fight with a friend, something happening at school. We can't prevent that from happening, but we can prevent them from dying during those experiences. So, and not to minimize what the pain that young people are feeling during this time, but again, some of these instances are things like, you know, the parents took the phone away, or there's some restriction on them seeing friends or something like that. These are, in the moment, they feel like a really big deal to this person. But even a few days later, when I'm talking to them in the ICU, they say, you know, it was a very temporary thing. And so we really don't want young people dying from that. And we have young people in Vermont who are dying in those types of circumstances because they pick up a firearm.
Okay, we're going to have one quick question.
Yeah.
Mark?
Actually,
Two quick questions.
what's the youngest, in your experience or knowledge in Vermont, what's the youngest age of someone who completed or attempted suicide? And the second question is about the time. I know as a nurse, we at UVM, we use the Columbia suicide screening tool. What's the timeline for the screening tool that you mentioned about accessibility to firearms? Are hospitals actively looking at adding that to all units, just the ED?
Great question. We're starting that, and I have a slide later on that effort, but it's not universally being done right now. And I don't know for attempts. I don't know the youngest. That might be something that Caitlin might have. In terms of, you know, I've had 12-year-olds that have died by suicide in Vermont. I had a 10-year-old working in another state who died from a firearm. Unclear what the intent was, but so pretty young. And we're definitely, I don't know that we can really, it happens rarely enough that it's hard to really look at trends, but overall it's definitely not getting better in terms of the age of both attempts and deaths nationally.
Thank you, and that's heartbreaking.
So we're gonna have a couple more questions, Leslie, and then Alan, and then Becca says, Daisy, so sorry. Becca says, I don't have your slides. You kind of need to tell me if we need to stop the questions to make sure we get through everything. So,
Okay.
So Leslie and then Alan.
So, and you may not be able to answer this, but we're asking our universal population to make a change in behavior and as a public health effort. And what do we know about how to do that works? Because that's that's a broad ask, especially looking at Vermont, compared to the data in other New England states that was in one of those maps.
Yeah, and I think I do have slides on some of the ways that we talk about this that we have found to work in terms of changing behavior. So I might just address that when I get to that.
Yeah, thank you.
And then we can come back to it. Yeah.
That
Yeah.
sounds great. Alan?
Yes, I'm a little confused with the numbers. Most of the suicides are adults, young adults from 24 up. What's the number of adult or children from 1 to 18 that has actually committed suicide with a weapon?
I don't have the number offhand, but it's a handful in Vermont every year.
And I'm sorry, Becca, we can also direct, when we're done with yours, Alan, I'll direct you to where that data is on the presentation. Great. Go ahead, Becca.
And I guess I do just want to add I don't have a specific slide on this, so I'll just mention it. That, yeah, for sure, we had the older folks are more commonly are dying by suicide in Vermont. And obviously, as a pediatrician, my focus is on the pediatric population. I will say a pediatric suicide death is devastating. It is devastating for the family. It's devastating. These are people who are kids are very active in the community. So they're in schools. They have siblings in schools. They have teachers. They have coaches. They have teams. And so it is, although the absolute numbers may feel small, the ripple effect of all suicide.
Uh-oh. Is that us? We lost you for about 10 seconds there, Becca.
Okay. All right, I'll just move on. I'm not sure. I don't want to repeat myself.
No, that's fine. And if I can just interject real quick. So just so everyone knows, we will continue testimony and we are working to have the older population and the veteran population also come in community and provide testimony on what they're seeing in those populations. So we will cover all age ranges. Thanks, Becca.
Sure. So I'll say as an intensivist, I cannot really think of many things in medicine where we have far more deaths than ER visits. So this is data from the health department this is back in 2019, but on average over the preceding years, there were almost twice as many firearm. This isn't just suicide. This is any type of firearm injury or death. We have twice as many almost deaths than we even have ED visits. And this just highlights again that as someone who works in a level 1 trauma center and takes care of pediatric traumas and I feel really good about what our trauma teams can do. I feel really good about what our ICUs can do. We can really help patients with very serious traumas, but we cannot help people who've used a firearm in a suicide attempt. They oftentimes don't even make it to the local emergency department because these firearms are just uniquely fatal and irreversible. Okay, so we'll talk a little bit about why we think providers can be helpful in talking about firearm safe storage, screening, and counseling. And so we interact with kids or with adults on a frequent basis. We're already talking about safety screening. So whether we're talking about the pediatric population.
Sweet Jesus.
Is it us?
And we do have
Becca,
have evidence.
Becca, I don't know if you can hear me, but you're frozen. So
Okay.
Maybe you can you want to try turning off your video, Becca?
Okay, good idea. Yeah. Sorry, I'm at work too. I figured the internet connection would be good, but you never know.
No worries. So if you can just start this over, that would be great.
Okay. Okay. And if, just interrupt me if I'm having trouble, and Tom can also take over because we put these slides together. So healthcare providers are really well positioned to have conversations about firearm safe storage because we're already talking about safety. We're already giving anticipatory guidance. We're talking about home safety. And so we're well positioned to sort of talk about this, in the context of safety and prevention. And we do know that this type of these types of conversations can be helpful, but screening and counseling are just not occurring as often as they could. So what we and we also know that there's a lot of barriers. So there's a time barrier, which is a big barrier, but others that Tom and I found in searching the literature a few years ago when we went to set about addressing this, is that providers will say that they don't know enough about firearm safe storage to really talk about it. They don't even know how to start the conversation, and they're really worried about alienating their patients. And so we looked at what was available in terms of educational modules for providers, and found some of them to be a little bit long and cumbersome. And so we set about to create a shorter educational module that providers can use. It's really geared towards healthcare providers, but also others could benefit from it as well. And so we were able to do this through grant funding and through the support of the Vermont Child Health Improvement Program, and created this short module that really concisely reviews firearm safe storage options. So what are the options? And then how do we actually talk about this? So we sort of skip over like the why. Healthcare providers at this point all agree that this is an important topic, but they just don't know how to start. So what we have found through the literature search and other types of focus groups and stakeholder interviews is to really use open-ended questions. And so the way we recommend asking the question, and again, to do it in the setting of talking about other types of safety and prevention, is to say, how are the firearms stored? So we use a presumptive question. And again, this makes sense in Vermont, just under half of all households have firearms. And so we should ask, how are the firearms stored, instead of saying, do you have firearms in the home? And it's not important for us to know like how many firearms someone has or exactly where they are. And we want people to feel comfortable having a general conversation about safety. And so we also encourage providers or discourage providers from looking like they're recording anything. This is a conversation about safety. It's not like an inventory of someone's firearms. That's not what's important. And we have found that stakeholders have really told us that preventing theft is really important to them. And so oftentimes it's hard for parents to imagine, their teenage son, having a relationship breakup and then using the firearm in a suicide attempt, but they can imagine, or they do worry about people maybe who really don't have access to their home, like an intruder, stealing their firearm, or someone else getting access to their firearm. So we talk a lot about unauthorized users getting a hold of their firearm, and that seems to be a good motivator to want to store the firearm securely. And then we also encourage families, if a family says they don't have firearms in the home, to ask about unsecured firearms where their kids play. And that's important because, again, we do know that just under half of Vermont households have firearms. So it's very likely that, your child may encounter a household with firearms. And then there are various handouts that we can give to families and to providers. This is from the American Medical Association to talk about the different ways to secure firearms. And this is also included in the module that we put together. I'm just gonna just scroll through this quickly just so you can get a sense of some of the materials and resources. And we've also found that people really respond to local messaging. And so this is something that the UVM Medical Center through the Injury Prevention Program put together with the same idea. So talking about different types of safe storage options. And we're using this as well as the modules to train providers in a pilot program right now at UVM Pediatrics. And they have these brochures and other resources as well as cable locks to give to families. So that is a sort of ongoing pilot program right now. And then nationally, we have some courses that providers can take that are free and available to anyone. You don't have to be a pediatrician. You don't have to be a medical provider to have access to these courses. And we have some Vermont influence in both of these. So you heard a little bit about CALM, which is Counseling on Access to Lethal Means, which is a great course. It's always been adult patient focused. And there's a new CALM out for pediatric providers. So specifically Counseling on Access to Lethal Means to Prevent Youth Suicide. And Elliot Nelson, who is a retired pediatrician, was part of the group that worked on this. And then I was part of the group that helped with the course on the right, Safer Storing Firearms Prevents Harm. And this, I'll mention it just a little bit because someone had asked about how to actually create behavior change. So again, this came out last year, and there was a lot of, again, focus group interviews, talking to firearm owners to think about how we can present this information and how do we best counsel families. And so this is similar to the module Tom and I did with a much higher budget and actual actors, acting out the scenario. But we use something called the good, better, best framework, which is to say that Tom had mentioned that the research shows us that storing firearms locked, unloaded with the ammunition locked and stored separately is really the best. Each of those is protective, and then it has an additive protective effect. But we also know that some families aren't there, and it might take them a while to get there, and they might not get there. We need to give them the information, but also understand that we can get them to safer or better, even if we don't get them to the kind of best case scenario. So some of the scenarios we have in this module really talk about how to work with the family just to get them to a safer place, even if it's not totally the ideal situation. And there's cases too on of course, I've found families with young children, toddlers, are more likely to store their firearms securely. And then what ends up happening is as young people, say in Vermont, are as the children become adolescents, they might be hunting or shooting with their family. And in that case, oftentimes the family will say, okay, you're in charge of, storing your firearm securely. And we really need to do a better job of letting our families know that these young people really shouldn't have unsupervised access to their firearm. Because when we review the cases of, for instance, in child fatality review, a lot of young people use the firearm that's sort of designated as like their own firearm in their home. And so a lot of families say, my adolescent took a hunter safety course, they know how to be safe. And so what they're really thinking about is prevention of unintentional shootings, which is important. But what we're really seeing in Vermont are suicide deaths, and young people will use a method that they have access to and that they're comfortable with, which is why we really need to talk about no unsupervised access, even for adolescents who may have taken like a safety course. And then just quickly, we did actually, this is new information, we did actually survey folks across the country who have taken this module to see if it improved their confidence and their counseling frequency. And this is not yet published data. It's been submitted and it was presented at a national conference early this fall. And we did find an increase in counseling self-efficacy, so confidence in the provider in their ability to counsel on this topic. And then also they reported that they were doing it more often now. This was short-term follow-up, and we definitely need more longer-term follow-up on providers and to make sure that they're continuing to counsel with universally with every visit, with every well child visit. And this is just some of the qualitative feedback that we got from participants about just feeling more confident in counseling more often. And someone asked about the UVM health network. So what is underway right now is a development of a suicide care pathway within the electronic medical record system. So this is exactly what the question was referring to. how do we universally add this to the list of things that we talk about with our patients? So this is going to be applied to patients 12 and above, where there's going to be screening tool, risk assessment and stratification. So it's not just screening, it's then identifying, okay, where does the risk level fall? And then who do we need to refer promptly? And what are the pathways to do that? And it's going to be standardized across the health network. So not just at UVM Medical Center, but all of the clinical sites, starting first with emergency departments and inpatient settings. And then the plan is to go to outpatient and primary care settings. And then of course, we'll have to assess how this is utilized and what the outcomes are of implementation of this suicide care pathway. So this project started planning last spring. So it's not yet implemented within our electronic medical record system, but will be implemented shortly. And then this is just the last project I wanted to let you know about, because this is pretty new. So a new website, gunsafevermont.org, is going to be hosted, and it's going to go live next week, actually next Wednesday, hosted by the U.S. Attorney's Office of the District of Vermont. And this is a collaboration between all of these agencies and organizations that you see below to promote safe storage. And this again goes to, how do we get the word out? How do we prompt behavior change? Who are the people that who are the trusted messengers in this effort? So there's going to be this website, which will be one place where people can go to with information. And I'll talk a little bit about what the information and resources there are, but also some PSAs that through both radio and television public service announcements about safe storage. So this is a screenshot from one of the TV PSAs, and all of the PSAs mention safe storage and what that is. So unloaded, locked, and away from ammunition. So every PSA mentions that. And then there's some variations on the PSAs. One is related to free gun locks and locations. So the Sheriff's Association was able to get 5,000 gun locks, which are now going to be available and distributed throughout communities in Vermont. And so some of the PSAs are going to be focused on the free gun locks, and then some of the PSAs are going to be focused on what to do if you or someone in your home is in crisis, and how to remove guns from your home. So this is another screenshot from one of those TV ads that's focusing on those who are in crisis, with the recommendation to find temporary safe storage sites outside of your home, and to consider temporarily removing firearms from the home. Now, this has been an effort that has taken many years to really to streamline, I will tell you. And I clinically had issues where I've been counseling families on about firearm safe storage, and we've come to the decision that the family is willing and agreeable to removing the firearms temporarily from their home, because they have in my case, a young person who's done something really impulsive, and they're at high risk for firearm suicide. And figuring out how to do that, the process of how to do that, is actually has been quite challenging. And so this has been a big lift on the part of Vermont State Police, and also Carolyn Hansen out of the Vermont AG's office has worked really hard on figuring out how we provide resources for people to remove their fire. This is temporarily and voluntarily removing firearms and storing firearms. So when I mentioned that story of talking to a family who said, yeah, it's not hunting season, we think it's a good idea to remove our firearms, there was one place in the state that they could go to. And so state police have worked hard to get additional FFLs, federally licensed firearm dealers, to agree to store firearms on a temporary voluntary basis. and then to create this map with resources so that anyone in Vermont can go to and look at this map and see what's sort of closest to them and what information they need to go ahead and store their firearms temporarily. This is right now, all this information is on Vermont State Police website, but it will also be included on that new gunsafevermont.org website that I had mentioned. And the folks, VSP did put out a press release about this about a week ago. And so I'll be interested to see if there's been an uptake. But part of this PSA that is happening is to let folks know that there are more opportunities to store their firearms outside of the home. Now, one of the things we need to follow up on is a lot of these require storage fees. And so we need to figure out if that is a deterrent at all, and if we need to support, figure out how to support those costs, if that's something that's holding families back from doing this. And then also on the website, just in one place, which was like, I'm so glad we're finally putting everything in one spot. There's information also on relief from abuse orders and extreme risk protection orders. So it's really one place that someone can go to and say, I'm worried about myself, I'm worried about someone in my home. I can temporarily store the firearms if I don't own the firearms, but I'm worried about someone. Is this a relief from abuse order? Here's the link and how to think about that, or extreme risk protection orders. So it's all kind of in one place. And so I just have 2 more slides left, and that's really about asks. So I kind of went through all the stuff that we're doing as a medical community to try to reduce Vermont suicide death rates. And there's never one solution or one intervention that we can do that's going to solve the problem. But certainly in our efforts to encourage safe storage and to create time and space for people so that they can survive these oftentimes temporary crises, we do support and have been supporting for years legislation like safe storage or child access prevention laws or waiting periods, all for that same reason, because if we can delay a suicide attempt, or if we can make that attempt less lethal, we are going to save lives. So these are efforts that are supported by the Vermont Medical Society, the Vermont chapter of the AAP, and the University of Vermont Medical Center, and in the past have supported. And then I heard I think it was Representative Black ask about if you have unlimited resources, what are some other asks? And I do personally support I work with the Vermont, or I work in partnership with the Vermont Suicide Prevention Coalition, and they have a list of legislative priorities, including 988 funding, additional DMH funding to expand zero suicide, creation of a suicide fatality review board. I think I've learned so much in reviewing our child deaths, and it really requires many, many months later, gathering the documents and really taking a deep dive into understanding what's going on in these cases. I think it's been really eye-opening for me. So we do this, we review all the pediatric suicide deaths, but that's not true across the board for adults. And school-based initiatives are going to be really important as well. So I support those asks from the Vermont Suicide Prevention Center. And then just as a last slide, our suicide death rates in Vermont are consistently higher than the US average. Intentional self-poisoning is increasing in Vermont, especially among youth and females. Firearms are used in the majority of suicide deaths in Vermont. And impulsivity is a major factor in these deaths. So keeping people safe during a temporary crisis can save their lives, and safe storage is a part of that, especially for young people. And we know that only half of Vermont firearm owners store their firearms locked and unloaded. And it's going to take a multi-pronged effort to, I think, move the needle on that. We think, the data from 2018 to 2020 is about the same in terms of safe storage practices in Vermont, in terms of the survey respondents. So on our end, doing training providers and how to have these conversations, and making it easier for folks to store their firearms, making it easier for us to have these conversations, to talk about it, to educate the public through PSAs. And then also legislative policy changes as well. All of that can help contribute to reduce our firearm suicide death rate in Vermont. And that is our last slide. So I'll keep the slides up in case people want to go back to it, open it up to questions.
Thanks. We do have a couple questions. We won't keep you much past 12, I promise. We have Mari and we have Leslie.
Thank you, Dr. Bell. That was very illuminating, very helpful. I have just a request or a comment. I noticed in one of the images for safe storage where the model is putting a handgun into the safe, they have their finger on the trigger. So I think if maybe you could replace that slide, because I think we also need to focus a little bit on safe handling, not just safe storage, to prevent accidental firing of firearms.
Yeah, and I think that might be a screenshot from the PSA. So I will just make sure that the folks who put that together, I don't know if I caught the screenshot at a weird time, but yes, I'll make sure I'll replace the slide for sure, but I'll also make sure that the video is appropriate.
Okay, thanks.
Yep, thank you.
Leslie?
Yeah, thank you, Dr. Bell. The work is impressive. I'm from the southern part of the state, so I know that you are working at UVM, and I'm wondering how this work might get down to the southern part of the state through the chapters, I guess, of the AAFP and AAP. But yeah, beyond pediatrics into family medicine, which also does a lot of work with families. So I was just wondering if there are thoughts going on about the southern part of the state.
Yeah, absolutely. Thanks for mentioning that. So yeah, I'll start with the pediatric network, in which we have a pretty tight group throughout the state that absolutely includes the southern practices through the Vermont Child Health Improvement Program, does these sort of quality improvement projects. And there's an entire network of practices that includes most of the pediatric practices in Vermont, but also quite a number of family medicine as well. And so we have been that's like a great network for us to disseminate this information. And then I think beyond that, though, if we want to include, we're hoping after we do this pilot study at UVM, general pediatrics, we do have data that when we give out cable locks or safes, even that increases the effectiveness of these interventions. So we do want to make that available to other practices as well. But certainly everything that we can think about in terms of making sure that we get this information out to, and then Tom and I have done presentations to the Vermont Medical Society, which also would include, all types of medical providers throughout Vermont. But if anyone has any other ideas of how they want this disseminated, we're happy to get involved.
Thank you. I'm going to think about that.
Great.
Any other questions? I know it's been a long morning. Thank you both. We appreciate your testimony and your time. And if you can just send the presentation to Claire, that would be great. Thank you. Have a great day.
Thanks for the opportunity.
Bye-bye.